Well, hello, everybody. We're going to get started. Thank you so much for joining us today for the webinar launch of the Rural Produce Prescription Toolkit. My name is Kelsey Zubik, and I'm the Director of Health Strategies here at Share Strength's No Kid Hungry campaign, and I am delighted to welcome you to this event. Before we get started, I'd like to remind participants that this webinar is being recorded and that the recording, as well as the toolkit, will be made available to all who registered. You are joining us now in listen-only mode, but we do want to hear from you. And so please use the Q&A chat function at the bottom of the screen. Please type in your questions and comments at any time during the webinar, as we look forward to a brief question and answer period with you at the end of the presentation. Next slide, please. The No Kid Hungry campaign is working to end childhood hunger in all 50 states through a combination of grants, strategic assistance, advocacy and awareness, and tools and services. No Kid Hungry is helping kids, families, and communities get the food resources they need. Identifying and mobilizing strengths is at the core of our work, and today's webinar on rural produce prescriptions is a result of this effort. We've seen produce prescription programs proliferate over the last 10 years, and we're reaching a turning point in this country in terms of proving the concept that produce prescription can be a tool for reducing food insecurity and for increasing dietary health. And yet much of the research available to help support these programs has been largely focused on urban settings. With nearly a third of our grant making here at No Kid Hungry focused in rural communities, we understand the value of research geared toward unique rural experiences. And as you know, rural areas make up a disproportionate share of the communities where residents have high levels of food insecurity. Research from Feeding America shows that while 63% of the counties in the US are rural, 87 of those counties had the highest rates of overall food insecurity. Given this disproportionate impact on rural communities, we wanted to make sure that there was adequate access to the rural experience of produce prescription programs for the benefit of those communities. And through partnership with Vouchers for Veggies and in collaboration with so many local programs in different regions of this country, No Kid Hungry has been able to fund and share a rural knowledge base for effectively implementing produce prescription programs. So thank you so much for coming to our collective big kickoff today. Next slide. In today's webinar, launching the Rural Produce Prescription Toolkit, we're going to provide some background and context that brought us to creating this toolkit, as well as provide a high-level overview of main concepts and core learning. And we'll do this while sharing perspectives from the field. We'll conclude with some resources and a funding announcement, as well as hearing from you in our Q&A opportunity. Next slide, please. Our speakers today include trusted partners and experts in this work, 2 members of the Vouchers for Veggies team, and 2 additional produce prescription practitioners. So first, I'd like to introduce Melissa Akers, MPH, CPH Program Director. Melissa is manager of the Food Policy, Health, and Hunger Research Program, directed by Hilary Seligman at University of California, San Francisco's Center for Vulnerable Populations. As part of this role, she is also director of the Vouchers for Veggies, ESF program, a produce prescription style program based in San Francisco. Since its inception in 2015, Melissa has played an instrumental role in the design, successful implementation, and rapid scaling of Vouchers for Veggies in San Francisco, and now focuses much of her time assisting other communities interested in replicating the Vouchers for Veggies model. Our next presenter is Kelsey Long, MPH, Program Manager. Kelsey Long is a project analyst with the Food Policy, Health, and Hunger Research Program at UCSF Center for Vulnerable Populations, where she works with Melissa, of course, and Dr. Hilary Seligman and the Vouchers for Veggies team to support projects and research related to food security and health. Before joining the team at UCSF, Kelsey was a high school mathematics teacher. I did not know that, Kelsey, and worked for community-based programs focused on improving nutrition and access to healthy food. I'd also like to introduce our guest speakers today. We have, thank you, next slide, Dr. Lydia Kim, MD, MPH pediatrician. Dr. Kim is a pediatrician who has worked at Northern Navajo Medical Center since 2015. She has been the pediatrics team leader in Shiprock for the Navajo Fruit and Vegetable Produce Prescription Program since 2017. She is interested in food sovereignty and access to healthy foods. Thank you for joining us. And also Sam Hoffler, MS, Food Program Manager. Sam is part of the food team at Reinvestment Partners. She manages Reinvestment Partners' produce prescription programs, guides program evaluation, and contributes to policy and advocacy work. Before joining that organization, Sam was the program evaluator and food systems lead for a SNAP education program. She brings a critical perspective to food work. So as you can see, we have just wonderful resources here with us today. So let's get started. I'll pass things over to you, Melissa.
Thanks so much, Colleen, for the warm introductions, and hi everybody. Thanks for being here. We're really excited to present about this today. So as Colleen mentioned, I'm Melissa Akers, and I'm with the Vouchers for Veggies program, or as it's known in San Francisco, ESF. So just a little bit about our program. Is that we are a produce prescription style fruit and vegetable voucher program that's based out of the University of California, San Francisco, UCSF. And the program was started back in 2015 by Dr. Hilary Seligman, and really as a way to address food insecurity, healthy food access, and support the local food system economy in San Francisco. Since then, we have rapidly expanded the program both in San Francisco and also in other communities. And so you may be asking or kind of wondering why somebody from San Francisco is presenting today on a webinar about rural produce prescription programs. But this kind of here is a bit of the answer. So in our work, as we were expanding and replicating our program outside of San Francisco, we have spent a great deal of time working with local health departments, community-based organizations, and other national partners such as Share Our Strength to replicate our model in other communities. And it was really this work in Cumberland, Virginia, a rural county in Virginia, that really led us to feel the need for resources specifically developed and tailored for produce prescription programs in rural communities. And so then this toolkit was born out of that work. Next slide. And so just to kind of level set for everybody here on the call about what is a produce prescription program. And I will say that this is thanks, this great graphic here is thanks to the National Produce Prescription Collaborative. But also I will say that there is no kind of hard and fast set standard definition for what is a produce prescription program. But this does a great job of outlining it. So it basically happens when a participant or a patient is screened for eligibility. And that eligibility might be that they are facing food insecurity or have a diagnosis of a diet-related chronic condition, amongst others. They are referred to the program by a provider, and where they then are enrolled and receive a produce prescription. That prescription is then able to be used at a food retail or farm direct a location to be able to purchase fruits and vegetables. And then also you'll see that some programs, not all, have a component of nutrition education or evaluation. Next slide. And And I could talk about this probably for the whole hour, but I won't. There's really strong evidence that has been emerging over the past several years about produce prescription programs and really the impact that they can have on a participant and also the broader community. We have seen that they are able to improve a participant's health. We've seen improvements in nutrition knowledge, self-efficacy, the ability to purchase healthier foods. We've seen improvements in food security, and there's also emerging evidence around the cost effectiveness of produce prescription programs. Next slide. We have also seen over the last several years, we have seen the produce prescription model just really flourish across the country. This graphic is from DIESA's PPR scan report that shows nearly 100 active produce prescription programs in 2020 across the country. The great thing about this is that we see that there are so many programs that are emerging. What we also start to see is that they are predominantly concentrated in more urban areas. We see a lot of these programs in the Northeast, in kind of the upper Midwest, the Northwest, in California, but we see that there's some gaps. We see in the rural South, in the Midwest, in the Plains, we see that there's not as many programs. Next slide. And I think that coupled with the lack of produce prescription programs in rural communities, along with, as Colleen mentioned earlier, that we see increased risks of food insecurity and poverty, along with very unique challenges to accessing healthy food specifically in rural communities. And so it was out of all of this and in our work in Cumberland, Virginia, that we really started to see that just what could we to address the gap in tools and resources that were specifically developed for rural produce restriction programs. Next slide. And so out of that was born this toolkit that we are kind of about to kind of take you on kind of a roadmap of. And when we designed this, it was not meant to be perhaps the longest, most comprehensive resource out there. It was really designed to be a user-friendly guide for planning and operating produce prescription programs in rural areas. Next slide. And so again, because we are based in San Francisco and are not the experts on this, we really wanted this toolkit to be informed by the experts, probably by many of you that are on the call today. And we wanted to really lift up the voices and the perspectives of practitioners, of those that are operating these programs in rural communities. So we did this by disseminating a national survey to rural produce prescription programs, as well as following that up with a series of in-depth interviews that span from program operators, program coordinators, nutrition educators, clinicians, really covering a broad sense of the teams that make these programs possible. Next slide. And just some of the interesting things that came out of the survey responses is in the program models. And this is something that we will elevate later in the webinar, but we saw that that half of the respondents are utilizing a CSA or produce box type of model, which really addresses transportation, some of the transportation issues. And we saw that almost half are using a paper voucher, and that over 15% are now transitioning over to electronic options. And then we also saw tokens and loyalty cards. And I know that this adds up to more than 100%. People were able to select more than one option. And then we also saw some of the common challenges coming out of the surveys was that, as you all probably know, transportation, funding, sustainable funding, access to grocery stores, the availability of year-round produce and partnerships were really some of the common themes that came out that everybody kind of has some struggles with. Next slide. But also on the other side, we really saw some common strengths and assets coming out of rural communities. We saw a great sense of community connectedness and a culture of collaboration, really understanding, I think, that when you're living in an area where there might not be as many resources, that we really saw kind of networks forming to work together to secure funding, to run programs, and they really understand kind of what are the unique needs in the community. Next slide. And so here we are going to just kind of jump in today and provide you with a roadmap overview of the different sections of the toolkit and what they entail. Now, by no means, we have a lot to cover and we're going to do our best today, but this is definitely just going to give you kind of a flavor of what is in the toolkit. And really for today, what we are going to do is we are going to pull out kind of some of the highlights from each section, as well as some of the kind of considerations and recommendations, along with some great examples of some of the innovative solutions and programs that we kind of found through this journey. And these are the different sections. And now we're going to jump into the first one, and maybe one of the most challenging for all of us, which is funding for produce prescription programs. Some of the common challenges that we heard kind of time and time again was that oftentimes in rural communities, there's just a smaller pool of funders that they felt like that were interested in funding. That funds often don't cover participant transportation, which we know is such a barrier, or technology and infrastructure costs. But sometimes it's difficult to compete with those larger programs, and there's the lack of sustainable funding. Next slide. So by no means, I wish that what I was going to tell you today was a silver bullet, but it really is not. But I'm going to outline some of the available funding options that now and that are on the horizon for produce prescription programs. The first is our grant-based funding pathways, which we are all intimately familiar with, I think, and we know the pros and the cons. So grants is often something that we have all, that private or philanthropic or foundation grants are something that I think we've probably all sought. They tend to be short-term and can, priorities can change with funders, but they are often a great tool for piloting your program, for establishing seed funding, and then for building and creating a more diverse funding portfolio from that. Next slide. We also have seen grants through government agencies that I just really quickly wanted to highlight. Probably everybody's familiar, but if you're not, I highly suggest you become familiar with the GusNIP program, the Gus Shoemaker Nutrition Incentive Program, and visit the nutritionincentivehub.org. They're a great website for more information. And also I would like to call out that the funding announcement, there's a funding opportunity that was released last week by the USDA to support produce prescription programs. So encourage you to check that out. And then also with the CDC, this presents a really kind of unique opportunity through their SPAN, HOP, REACH, and BRIC programs. This is a great way if you partner with a local health department in your community, or you want to partner with a local health department. The CDC funds them, and has expressed great interest in produce prescription programs as falling into their portfolio under these programs. And then also emerging is SSB, or sugar sweetened beverage taxes, that right now we are seeing them mostly in urban settings, but I think this is gaining momentum across the country, and we will see more and more of these taxes as ways to fund produce prescriptions in the future. Next slide. And we wanted to call out an example of a great example from the Marion County Public Health Department, and how they leveraged CDC REACH funding to support their produce prescription program. So just wanted to call out that great example. Next slide. So here is an area where, again, we could probably spend a whole hour, but we won't, but it's really exciting just to give you kind of a sense of there are new emerging healthcare opportunities to fund these programs. It's through Medicaid, but it is very state specific. So I encourage everybody to become aware of your kind of state Medicaid plan and potential things that are coming down the pipeline as it pertains to managed care organizations and their use of the in lieu of services option to show that produce prescriptions can be a cost-effective substitute and be a covered benefit. We've also seen examples, and we'll hear from Sam in a little bit, about Section 1115 demonstration waivers and the different waiver opportunities. So we are going to see, I think, more coming in the future about opportunities for sustainable funding through healthcare. Next slide. And this is just going to, we have really exciting, we saw great examples through our interviews of different produce prescription programs in rural communities that are really leveraging their strong networks and sense of collaboration in their communities to secure funding. So whether it's funding through sponsorships with a local bank that has greatly supported their program in Rutland County, or a partnership with the Food as Medicine Tompkins group that partnered with a local college in order to support their grant writing and grant applications. And so now I am so excited to turn it over to my colleague Kelsey, where we are going to hear a perspective from the field about how their program has really been able to expand and grow through using diverse funding sources.
Awesome. So thanks again, Sam Hoffler from the eWell Produce Prescription Program in North Carolina for joining us today to speak about their funding innovations and rapid scaling of their program. Sam, can you briefly tell us about the Eat Well program, where it operates, and your role as the food programs manager?
Hi, yeah. I really like our logo and the state there. I feel like we've got it all there with my head. At Reinvestment Partners, we do housing and we do food, and I manage the food programs here. Our produce prescription program, as you mentioned, is called Eat Well. And basically, we electronically deliver funds for fruits and vegetables to folks so that they can shop at Food Lion, which is the largest grocery retailer in North Carolina with 500 locations across the state. So the program is currently statewide, and so far, Eat Well participants have spent about $5 million in fruits and vegetables.
Wow, thank you for that and for that context. So in your role, what do you see as some of the biggest challenges and barriers faced when it comes to implementing Eat Well in rural communities?
This is a great question, and I think I want to start by kind of saying what Eat Well gets right. So first, we did a survey of about 30,000 people, and we found that 97% of them, almost everyone, shops at Food Lion at least half the time. And so we sort of realized through that it's the right price point, and people are already going there to shop. So that's the biggest strength of our program in general, and I think in particular in rural areas, that we meet people where they are, and we try not to over-engineer a solution if people are already doing something. And so we are kind of trying to tap into what people are already doing, their behaviors and habits, and we're trying to figure out what best suits them. And so our biggest challenge has actually been serving Western North Carolina, and that's a challenge for agencies in Western North Carolina across the state, statewide agencies. It's mountainous and difficult to connect across counties and across towns. And so trying to do something at scale is really challenging, given that our main partner doesn't have as much of a footprint over there. And so right now what we're working on is getting the local grocer there on board with this program. And so I think it speaks to how program design, if it's a good program design, can be easily adapted for a particular need in a community. And that's where we are right now.
Thank you for that. And so we've talked a little bit about, and Melissa talked about earlier, that funding is a consistent challenge for many produce prescription programs, and that's particularly true in rural communities. Eat Well is a great example of a produce prescription program that utilizes multiple funding streams to rapidly expand the program. Can you share with us how you all access these different types of funding and what each type of funding has allowed you to do for your program?
Yeah, so like most produce prescriptions, we started out with GusNIP or FENI funding back in 2017. And we started at federally qualified health clinics. And so that's how we really started to build partnerships with the different counties in North Carolina. So we are working with federally qualified health centers in about 60 of the 100 counties. So that really gave us kind of like a home base, and that funding allowed us to refine our program design, get the model set up, test things, and basically do a proof of concept. I think the downside of the GusNIP or FENI funding, one example is like it can have eligibility criteria that may or may not work for who we're trying to reach. So just an example is like undocumented people can't be on that funding. So we kind of started searching for different funding after that. And we've received funding from the General Assembly of North Carolina, private philanthropy, and private health insurers. And I think the private philanthropy and even the state funding are both grant-based, right? So they're similar to the GusNIP model. And even there, we're looking at a way to fund this long-term, reliably for people, And we really like to see something that folks can use that will help their health over time. So we don't really want to see it end in like 6 months or a year or something like that. And then, as Melissa mentioned, we're also part of the CMS 1115 waiver project. It's called the Healthy Opportunities, where Medicaid is basically paying for non-medical health services. It's really exciting. It's a little clunky. But what's exciting about it is that we have a public payer who's going to be paying for these services. Like, people can get their rent paid for, or they can get food paid for. And that's something that we've never tested before. So we're really, really excited about that. And then one really big challenge to moving into getting funding from the healthcare sector is becoming a vendor with the healthcare partners. And so we basically had to become HIPAA compliant to get the contracts with private health insurers. So I know for some organizations that's too big a lift. And so I think that's something that around advocacy, and especially in rural areas, if it's a small organization, that's too big of a lift as far as accessing that funding. And so it's just we're just flagging that as it's a challenge if you want to move into that funding stream.
Absolutely. Well, you've spoken a little bit about this, but as your program has grown, how have your funding strategies changed?
As we've grown, I think we've been able to meet the needs of more people. And so as an example, we shifted from 1-by-1 enrollment when we shifted into the healthcare sector. So now we're doing online enrollment. So people we can actually use administrative data to figure out who's eligible and then affirmatively reach out to those people, and they can sign themselves up online. And so we have like a validation mechanism to make sure they are who they say they are and they're eligible. And I think it's particularly important for people in rural communities who may not be connected to, they might not go into the clinic, or they might not, be connected to some of these services. And so to be able to literally call them up or text them or email them and say like, hey, we want to give you money for food. We think you need it according to the data we have. I think it takes down one of the big barriers, which is just like how to reach people. And that's the first step. And the second step is making sure that the program meets their needs. And we also do that.
Absolutely. Well, thank you for your insight on that. I wanted to hear a little bit more about you. We've talked about your rapid expansion at the onset of the COVID-19 pandemic. Can you tell us a little bit about how you've had to tailor or streamline your program as a result of that expansion, and maybe also how that expansion has impacted your ability to reach rural communities?
Yeah, so we basically had to reconceptualize our program at the beginning of COVID to think of it more as an emergency food assistance program rather than just a traditional produce prescription. This was in part because even the food banks and other traditional sectors weren't able to meet the demand. It was just so outrageously high. And so we were able to kind of like catch some of that spillover basically. So we fully pivoted. We served about 37,000 people in North Carolina, in addition to the incredibly high demand that the food banks and food pantries were also meeting. And it was sort of a rare occurrence because for once money just wasn't the issue, right? Like we had federal funding coming down, we had different assistance coming down, but it was really capacity. And so we were working alongside the emergency food sector to adapt our program to feed as many people basically as we could. We set up a hotline with a local healthcare agency, and people could just call in when they needed food and they got enrolled over the phone. So from October to October of 2020, we enrolled almost 40,000 people. And we never done that before. And so it felt like it was like really testing our system and breaking in ways that were very helpful for us to learn. And I think what we did learn from it was that people really like it. They can shop when they want, where they want, they can buy what they want because the funds are restricted to a whole group of fruits and vegetables. But what we really also learned was that people who are disproportionately in need access the program at a higher rate. So we saw that about $1.5 million was spent by people in rural counties. So that means like their local grocery store, like that's where they were buying that stuff. So we actually injected about $1.5 million into those communities. And I think one example to highlight is Robeson County in North Carolina. It's one of the poorer counties in North Carolina. And we did offer the program as a universal kind of, anyone who needs food can get it. And what we started to see was that we were reaching older people, we were reaching people of color, we were reaching women, and we were reaching people in rural counties disproportionately. So once we did our final survey to figure out who actually accessed the program, even though we didn't have like rules on who could do it, that's who we found were accessing it. And so it was really cool to like disproportionately serve rural people with such a big program.
Well, absolutely. Thank you, Sam, for your time. We could really listen to you talk for all day, but we have, unfortunately, have limited time. So thank you for your time and expertise. And we really value your contribution to the field. And I am actually going to jump straight into our next section of the toolkit. With that, so as previously mentioned, Melissa mentioned, we won't be covering all of the details included in the toolkit. So for this partnership section, we wanted to pull out some common challenges and key strategies from our surveys and interview respondents. So we know partnerships are key to the success of any produce prescription program, but perhaps that's even more so true in rural communities because of unique challenges that are often solved by local partnerships. Rural programs commonly cited some of these challenges, such as even the knowledge of establishing community partnerships, a lack of staff and organizational capacity to establish and maintain partnerships, and a challenge of integrating their program model into the clinic or community partner workflow as challenges to establishing and maintaining partnerships. So we know that when we're starting these partnerships, it's important to get to know the community. Every community and every rural community is different, with each having its own unique networks. So it's important to understand the infrastructures and resources that are already available in the community. And this can be done by conducting a community assessment, whether that be formal or informal, to allow you to gain an understanding of the important community characteristics and potential partners in the community. The toolkit will outline and provides resources and common rural considerations that can guide you through getting to know your community, and including the answers to some of these common questions. It's also important to determine who you will be working with and who you're trying to reach with your produce prescription program. And while this might happen before you develop partnerships, it also can happen as you get to know partners in the community and assess the needs of the community. So the toolkit includes questions to consider, as well as other rural considerations that can help you to identify the need in your community. And as previously mentioned, for community partnerships, community connectedness in rural communities, it can often be was an often cited strength in rural communities, providing rural programs with a unique opportunity to explore partnerships with diverse community partners that may not be traditionally thought of as produce prescription program partners. Some examples that came up in our research include organizations such as Parks and Recreation, libraries, community centers that may be interested and invested in the health of community members, and as well as interested in supporting and partnering with different aspects of the program. So we know healthcare partnerships for produce prescription programs are very critical to the health and well-being of produce prescription programs. Developing partnerships with healthcare, it's always important to consider aspects such as capacity, the interest of the healthcare partner, and goals in the partnership. However, in rural communities, low staffing may mean that clinic staff are even more limited in their capacity to support program implementation, making it even more critical to ensure that the program can be flexible to meet the needs of the clinic partners, and clinic partners can identify and really envision how the program will fit into their workflow. This might mean considering working with staff such as community health workers or dietitians who can maybe have more capacity to support the program. Additionally, some rural communities, I think as mentioned, may not even have a healthcare system or healthcare clinics. And so it might be helpful to consider partnering with school-based health clinics and WIC agencies as well. Academic partnerships with local or regional colleges were often identified in our research as being useful to supporting evaluation efforts, program design, things like grant writing, IRB approval, and even leveraging for volunteer opportunities. So we encourage you to identify land-grant universities and cooperative extension programs located in your state and contact them to explore potential partnership opportunities. And finally, partnerships with food retailers, we know, play a pivotal role in the success of produce prescription work programs. So each rural community is unique, as we've mentioned, with its available food networks. So it's critically important to partner with food retailers in the community who are accessible, affordable, and well-known in the community. And as Melissa has mentioned, transportation was often cited as a really big challenge for rural communities where people often have to travel far distances to access food retailers as well. So rural communities may want to consider partnering with local agriculture, whether that be farmers markets, mobile markets, CSA programs, or produce delivery programs. That can be a valuable tool for many rural communities, providing community members with local and accessible produce options. As Melissa previously mentioned, 50% of the survey respondents noted that their program utilized some form of produce box, highlighting the strategy that this strategy may be a valuable one for rural communities. So effectively sustaining a produce prescription program requires consistent management of community partnerships. So we wanted to highlight here some of the best practices mentioned in interviews to help support and sustain these long-term partnerships. The first being the importance of paying community partners for their time and involvement in the program. Building these costs into the program, whether that be a stipend or a percent of FTE, can lead to more engaged long-term partners who are more likely to contribute their time and resources to the program. We're going to hear in just a moment from Dr. Lydia Kim about the importance of program champions and how they can contribute to the long-term success of your program. It's also important to engage in continuous internal evaluation to assess the needs for any program improvements, which is important to ensuring that your program continuously meets the needs of all partners involved. And finally, being available to your partners by providing them with ongoing training and technical assistance can be key to continuing and developing sustainable partnerships. So we are so excited, as we've mentioned, to have Dr. Lydia Kim join us today to speak with us about her work and experience as a champion provider for the Navajo FNVRX program. So thank you, Lydia, so much for joining us today. And Lydia, can you start by briefly telling us about your role with the Navajo FNVRX program and how that started and how it has evolved over time?
Sure. Thanks, Kelsey. I feel like I was nodding along with so much of what you were saying in these last few slides. There's a lot of really good points that you make. So I'm a pediatrician out at Northern Navajo Medical Center, which is in Shiprock, New Mexico on the Navajo Nation. We partnered back in 2017 with a local nonprofit called COPE, or Community Outreach and Patient Empowerment. And the goal was to distribute vouchers to help fund the purchase of fruits and vegetables to families in the Shiprock area. So we first started off with some eligibility criteria of families having a 3 to 5 year old with overweight or obesity. And eventually we expanded it just to all 0 to 5 year olds, just to kind of, catch all our families. Pre-COVID, the way we ran our program was a 6-month-long program where families came once a month, had an education session, and then received their vouchers afterwards. Post-COVID, as you were talking about with staffing issues, things like that, we started a new pilot program where we're linking voucher distribution and education with regularly scheduled well child visits. So definitely, when you talked about flexibility, fluidity, I think those things are super important just to keep the program going. And then, another thing that you were talking about, and I think Sam was mentioning too, just in terms of knowing the community and where people buy food. So, on Navajo Nation, it's a food desert. I think it's 10, I forgot what the latest, it's either 10 or 12 grocery stores in land the size of West Virginia. So we didn't just partner with grocery stores because there's so few across our reservation, but also partnered with trading posts, gas stations, other places where people buy food to get vouchers as well.
Awesome. Thank you so much, Lydia. So we've mentioned I've mentioned in the previous slide that you've been identified as a champion for the Navajo FNVRX program. How do you see yourself being a champion for the program, and what strategies, whether formal or informal, have you engaged in to build support for the program?
Yeah, so I think first and foremost, the most important thing for being a champion is just really building a support team. Because we're in a rural area, I think people's roles and clinical or work demands change all the time. So, you know, we had a team of people interested, and it's a diverse team too, interested in food security for our families. So just kind of understanding and respecting everyone's roles and the fact that it'll change over time. I think that was a huge bonus for our team, just knowing that some people might be able to step up where other people might have to step back over time. So we've been really flexible about who's kind of the clinical point person over time. So, at the beginning, one of the dietitians and I had a little more time to be, in clinic, in person. After a while, when we were pulled back because of COVID, we had one of our lactation consultants who was able to step up during that time. When she needed to take a step back, one of our case managers was able to step up. So really kind of being okay with the fact that it might change over time. I think that was a really important lesson for our team to learn. And then in terms of just getting other community support in place, because we're in a rural area, we got to know our local grocery store leadership. We bothered them a lot because there was initially some hesitation in getting involved in the program or accepting vouchers. So, getting to know them, meeting with them, whenever we had free time, just driving down the hill, and like finding their management. And then, knowing that the management is also from the community and invested in their own, family and kids' health too. I think that was, one of the reasons why, even though they were, initially not too excited about extra paperwork, they eventually got on board as well. And then I think you were asking a little bit about, non-clinical programs, how to get clinical programs or clinical, programs, I guess, engaged or involved. Just, I think, approaching the clinic directly. And then I think knowing that, it doesn't just have to be a provider or a nurse. There are lots of other people, as you mentioned in your previous slide too, right? Whether it's lactation consultants, right? They're also really invested and involved in maternal and child nutrition, dietitians, diabetes educators. There's so many other staff members, not just, direct providers or nursing staff, who are also really invested in health and in diet too.
Absolutely, and thank you for your insight into that. So I know in your role as a clinic champion, you've spoken to a few of them, but what do you see as some of the biggest challenges or barriers faced when implementing your program in rural areas?
Yeah, I think first would probably be staffing for us, just as a clinic. And so, learning to be flexible, like I said, just kind of understanding the most important thing we wanted was to get families their vouchers. So, especially during COVID, kind of realizing that it might not always be the same person who's the point person. I think that was a really valuable lesson for us, as I mentioned. That was a big thing. And then also, before COVID, we were, as I mentioned, having these education sessions once a month with families. That ended up being a big time commitment that we weren't all able to unfortunately invest. So then being flexible, trying to figure out how we could incorporate both education sessions and voucher distribution with the well child model. I think that's another, way we've been able to respond with staffing challenges. So that's one thing. And then I think also, both you and Sam also mentioned the transportation challenge, and that's definitely been a barrier for some of our families as well. So moving towards, if our families already have to be coming in for their well child visits, trying to incorporate voucher distribution and education with the well child visit, I think that has really helped. And then again, like also partnering with not just traditional grocery stores, because there is such a scarcity of grocery stores across the reservation, but also, talking with and partnering with the trading posts and gas stations. That's been another way that we've been able to address that issue.
Amazing. Well, thank you so much for your time today and your valuable time and expertise. We greatly appreciate you joining us on this call and for your contribution to this work. Awesome. Thanks, Lydia. So I'm going to now jump straight into the next section of our toolkit, which is our program design section. So as mentioned, we're going to pull out and talk about some of the common challenges and key considerations for program design and some key considerations as you are designing and even throughout the process of implementing your program. So a few commonly cited rural challenges to consider include staff capacity to enroll and distribute prescriptions, as well as participant capacity to pick up and utilize prescriptions, limited retail partners that offer high quality produce options, and the funds to support rural specific design considerations. So we want to start out by emphasizing the importance of having a diversity, equity, and inclusion lens throughout program design, implementation, and evaluation. We know many inequities may be exacerbated in rural communities where historically less funding may have gone to support community needs. Some examples we found it through our research of supporting an equity approach is addressing the access to culturally appropriate foods in communities, particularly in Native communities, addressing transportation barriers, lower literacy rates, access to local food options, and access to Wi-Fi or broadband technology. So seek out partnerships with BIPOC farmers and community-based organizations and identify potential disparities in the community and work and elicit feedback from partners and participants on how to best address those inequities. So when you start out with designing a program, you want to determine the prescription dose, length, and frequency. Given that there's no standardized prescription dose, frequency, or length, answer to these questions can vary based on a number of factors. So the toolkit provides some additional questions to guide you, as well as resources and other rural considerations as you make those determinations for your program. And as we've mentioned, it is important to make sure your program works well for the community you're working with. So in many rural communities where local food options are not available year-round, it's important to consider what you can do to offer year-round access to produce. So some really cool and best practices that we saw coming out of our research, many communities noted that there might be retailers outside of the community that participants are accessing that do offer year-round produce options. So if you're partnering with the seasonal farmers market, maybe consider partnering with additional or alternate food retailers during the winter months. Or some programs consider allowing participants to purchase canned or frozen foods or other culturally relevant foods, such as beans, that can be stored and last for longer periods of time. As well as some programs like the Purdue Extension Nutrition Education Program incorporated food preservation classes, teaching participants to freeze and preserve their produce to last longer during the winter months. So determining your produce prescription method, the majority of produce prescriptions still use some form of paper voucher, as we noted in our survey responses, as their primary prescription delivery method, although there's a growing momentum for the transition to emerging electronic methods that aim to facilitate scaling and streamlining of programs. So it's important to consider the needs of your partners and participants when taking close note, particularly in rural communities, of technology limitations and capacity of participants and partners. Some rural programs mentioned considering both paper and electronic options, such as the Cumberland Path program in Cumberland, Virginia, to better meet the needs of participants. So the toolkit outlines many important things to consider as more options emerge for produce prescription programs. Produce prescription programs are typically redeemed through either in-store purchases at brick and mortar locations such as grocery stores or corner stores. However, we've also mentioned farm direct options, but in contrast to urban communities where more options may be available to partner with in the community, rural communities may have more limited options, as we've mentioned. So in determining where and how your produce prescriptions will be redeemed, it's important to select options that are available in the community, accessible to participants, and affordable. And we really wanted to highlight, I know we've mentioned this multiple times, but transportation is consistently identified as one of the greatest barriers to accessing healthy foods for rural communities. So if you think that transportation will be a challenge for your participants, explore different strategies to address and support participants when designing your rural program. So and some innovative strategies that came out of our surveys and interviews include exploring delivery models or leveraging local volunteer networks, centralizing pickups for produce boxes at easily accessible options, or as Lydia mentioned, centralizing those pickups at healthcare clinics so participants can pick up their produce boxes at their clinic appointment, as well as utilizing Medicaid transportation to health appointments. And finally, transportation support, and including transportation support in your budget, such as gas vouchers and transportation reimbursements to support participants in redeeming their prescriptions. So I am going to pass it back to my colleague, Melissa.
Super, thanks, Kelsey. And thanks everyone for hanging in with us. In the interest of time, in the last few minutes that we have, I am going to do like a speed round of program evaluation and then leave a few minutes for Colleen to talk about the exciting funding opportunity that Share Our Strength has, as long as answer hopefully a few questions. So program evaluation, definitely, you know, a hugely important part of your program. Really trying to think of, you know, are you reaching your goals? Are you making an impact? Are you setting out to, are you accomplishing what you set out to do? These are all kind of questions that might be going through your mind when designing your evaluation. Next slide. I think that one of the most important things to do is to determine really your purpose. Is that what do you want to measure? And then also, what do you have the capacity and the ability to collect? Not all programs need to do a randomized controlled trial evaluation. It's okay to do, you know, just to measure what you are capable of measuring. Next slide. And so I think we've all seen kind of the different evaluation methods for produce prescription programs. We often see pre-post participant surveys, surveys of community partners, interviews and focus groups, and also especially with clinical partnerships, we are now seeing the ability to extract electronic health record data or claims data. And we see that surveys are often administered either paper-based or electronic. And I encourage you to utilize which method or both methods that work with your community. Oftentimes in rural communities, you may need, depending on Wi-Fi limitations or people's comfortability, you may need to use more paper options. But we are also seeing lots of surveys being administered via tablet through a text message, a QR code, or email to participants. Next slide. And then I have here is just being mindful of oftentimes, particularly in rural communities, there is limited Wi-Fi or internet access, which might lead you to use paper options or to utilize, like with Qualtrics, you can utilize on tablet-based surveys that work in an offline mode and then can be downloaded later. Next slide. And just as in supporting transportation, we really highly encourage offering some kind of a stipend as a thank you for participants completing surveys or participating in an evaluation. You will definitely see your survey completion rates go up, and it is just acknowledging everybody's time for completing an evaluation. Next slide. So we've talked about what an evaluation, but what are you measuring? What is in your evaluation plan? I highly encourage everybody to check out, again, the nutritionincentivehub.org website, where there is just a treasure trove of evaluation resources. And there is what's called the shared metrics, which the Nutrition Incentive Hub, the core metrics that they developed, and really all GusNIP grantees across the country are utilizing. So it would be great if everybody measures utilizing the same screeners, food security, fruit and vegetable consumption, and then there's a range of health metrics. And so that your program, you can then compare it and evaluate it to other programs out there if we're all using the same thing. Next slide is that there's also some optional metrics to consider and really think about, the unique aspects of your rural community and what you want to measure, whether that be looking at the food environment or food shopping patterns or participants' mental health. So again, check out that website for more information. And here are some examples of some electronic health record data that with your clinical partner that you might be able to pull out and extract. Next slide. And kind of in conclusion, I think when we're often talking about the data that we're collecting and things like that, it's sometimes we forget about why we are all here today. And I think that really is why the reason that we're all here today is the power and the impact of that produce prescription programs have and the ability that they have to address food security and health, not only of participants, but of the broader food system and local economy. And so I think with that, I will pass it back to Colleen for the final few moments and just really want to thank everybody for joining us today and encourage everybody to check out the toolkit.
Great. Thank you so much, Melissa, and all the presenters and speakers. You did an amazing job of covering the wealth of information included in the toolkit. That was a super dense abridged version, so much appreciated. A reminder to participants that you will get the not only the recorded webinar from today, but also a link to the toolkit following the presentation today. I wanted to call everyone's attention to other resources that are in the toolkit, just so as a preview, things to look forward to. And if you'll go to the next slide as well. There's also some additional things I wanted to call people's attention to. No Kid Hungry is excited to offer a funding opportunity to support clinical community produce partnerships interested in incorporating some of the findings in the Rural Produce RX Toolkit. The deadline for applications is May 20th, and there's an RFP webinar where you can get all of your questions answered about this opportunity next Friday on April 29th. And we've just dropped the live links in the chat so you know where to register and how to get more information. I also wanted to let everyone know about the Rural Child Hunger Summit taking place next week on the 27th and 28th of April, presented by No Kid Hungry and Save the Children. And of course, that we have ongoing research strategies and lessons on our programs page specific around rural communities. If you don't know about that, please visit that as well to find additional resources. We're almost at the very end of our time. We've been able to answer some of the questions already, but there are still a few outstanding questions. We have one question, and I'm going to condense things in the interest of time, but Mia Rogers from Chester County, PA, wrote in and asked mentioned that they often struggle to get larger community and municipal support in rural areas, often due to racial prejudice and discrimination against people living in poverty. Do any of the panelists have advice for working in those environments? Some of the panelists did mention, this is untenable. And I just wonder if anyone had anything else that they'd like to share about that question.
I think, thanks, Colleen. And this is a tough one to answer, and I know we don't have a ton of time, but yeah. I think the only thing I would add to that is that probably sometimes when making the case, and the nice thing about prescription programs is when making the case to different constituents, to different groups, is that there are so many different kind of impacts with these programs. And so let's say if somebody is maybe not hearing or not open to that this this reaches households with low income or is addressing poverty, you might look at it from or try to convince them or gain support through showing how these programs, like the health benefits for these programs or the cost effectiveness or potential cost savings for addressing some of these for addressing diabetes and the rising costs of some of these other like diet related health conditions. So I think it's kind of tailoring your message to different audiences to get their support.
Great. Thank you so much, Melissa. Just moving quickly on, I think I can handle this one. What type of data should be collected for these produce prescription programs and how is success being measured? A lot of that we heard about on the presentation. There's more information in the toolkit, but I'll just highlight visiting nutritionincentivehub.org. You can find lots of core metrics being used. And then lastly, with any healthcare partners, have you done any type of pop-up mobile farmers markets on site if you know transportation is an issue? And I'll just throw that out as our last question today.
And I'll add to that we have definitely seen examples of on-site or mobile farmers markets, farmer stands, mobile markets coming to the clinic, maybe once a week or once a month, at a predetermined time as a way to address, definitely as a way to address transportation.
Great. Well, thank you. That's all the time we have for today, but I appreciate everybody attending. Thank you so much to our speakers who generously shared their time and expertise. There's clearly lots more to discuss here. We hope that the toolkit becomes an ongoing resource for everyone interested in these efforts. Thank you again and have a wonderful day.